And Dr. Pasalakis, do you want to open up, and then Dr. Mayo will ask if you want to say anything first, and then we'll just go in order and answer questions.
Sure. Good afternoon. I thank the media for joining us virtually today for this announcement and for questions. Today, Governor Cuomo named Monroe County on a list of 35 counties where health systems can resume providing elective treatments and procedures to their patients. We have received separate confirmation from New York State Department of Health. This is good news for several reasons. First, it means that our community has successfully flattened the curve, and the risk of a dramatic surge in COVID-19 patients needing hospital care right now is low, assuming we continue with social distancing. This is a great testament to the people of Monroe County who continue to practice social distancing. It also shows the effectiveness of policies we have put in place to keep patients safe. We have restricted visitation in the hospital, and we have started universal masking not only for ourselves but for anyone else entering the hospital. As difficult as these practices have been for all of us, they are doing their job to prevent the spread of disease. Second, it means that families can resume getting the care that they need. As I've talked about previously, non-COVID illness is increasing as people have not gotten some of the care that they need. When we suspended non-essential procedures in March, it was a necessary step to open up hospital and clinic space for a potential surge in COVID patients. But many of the procedures and treatments we postponed in the near term are extremely important to the health of our patients. We look forward to providing the surgical procedures, tests, and clinic visits our patients need to feel better and to get well. COVID-19 will remain in our community for a long time, and we have made changes to ensure the safety of our patients in all settings. We will continue to use telemedicine when it's appropriate. When patients do need to be seen in clinic or hospital, they will continue to see staff members wearing masks. We will continue to ensure that patients remain distant from each other and take many other steps to ensure patients and staff members are safe. We're not fully open for business, but we are open for safe business. Before asking Dr. Mayo to say a few words, I should note that the governor's executive order applies to all clinics and hospitals in the UR medicine system. This includes Strong Memorial Hospital and Highland Hospital of Rochester, FF Thompson in Canandaigua, Noyes Memorial in Dansville, St. James in Hornell, and Jones Memorial in Wellsville. With that, I'll turn it over to Dr. Mayo. Would you like to say a few words?
Yes, thank you so much. Thank you, Dr. Pasalakis, and thank you to the News Corps for helping us keep accurate information available to our community. I want to echo his words that it's very noteworthy the way that the community has really come together and helped us flatten this curve. The curve flattening in Monroe County has been truly remarkable, and it's come through sacrifices as well as through commitment. I would venture a guess that many people in our community have made personal sacrifices from something as the inconvenience of being at home or changing your work patterns, and more substantial sacrifices of postponing needed surgeries or things that you were looking forward to in resolving in your healthcare. So we are very pleased that we can move forward with a broader criteria and selection criteria for surgeries and care throughout our health systems. We think this is a very important forward step for our community, and it's certainly an appropriate time to move forward. We've all been concerned about ensuring access to care and timely care for all of the members of our community and our patients. So this is an important day forward. The importance of maintaining social distancing and maintaining safety and infection prevention practices cannot be underscored enough. We really all have to continue to live with some of the inconveniences that are vital to our safety. Wearing masks in public, very significant attention to hand hygiene, environmental cleaning, all of these other measures, and there are too many to mention that the health systems have actually implemented to improve safety for the patients. But things that we can each do are important, and we need to keep doing them. So thank you to everyone for that, and then I'll turn the time to questions.
All right, thank you very much, Dr. Mayo. I'm going to, our first questioner is going to be Andrew Banis from 13 WAM TV. Can I ask, just in the interest of time and the two doctors, if you have a general question that you'd like answered by both systems, I'll ask if you can limit to one question. And if you direct it to one of the two speakers, then we'll do a question and a follow-up, which has been our drill in this. And then if we get through this in 40, let's say 40 minutes or so, and there are follow-up questions, we'll let those be asked. But Andrew, do you want to ask a question of both doctors or pick one?
This would be of both doctors. I wanted to ask about, this is the first step really where we're seeing success of flattening the curve. But one of the governor's mandates for reopening things is hospital capacity. Wondering if you can say where each of our hospital systems are right now in that capacity.
Yes, that's an excellent question. As you know, when all this started, we withheld surgeries to open up beds and open up space. Currently, we have more than 200 open beds, and our capacity far exceeds the 30% of ICU beds and floor beds that are needed. And that's the major reason why we believe we can open up as we are to elective surgeries, in that we have surge capacity should social distancing efforts start to fail and we see an upswing in COVID-19 patients. We can rapidly cut back on surgeries, open up more space, and we have a huge buffer for those patients at this time.
Yeah, and the same is true in Rochester Regional Health Hospitals. The initial efforts at improving or creating surge capacity were designed around reducing routine schedules and opening up time and space. We also partnered with the U of R to identify additional spaces within our facilities that could greatly expand our patient care capacity. And we do some of that on an annual basis during the height of the flu season, where sometimes our patient needs surge to a level that's greater than the room numbers of our hospitals. So those surge experiences gave us the experience and the knowledge on how to really provide extensive surge capacity in the face of COVID-19. So we feel ready and prepared, and we certainly have the capacity, and we can move forward meeting the governor's criteria.
Thank you.
Thanks, Andrew, for the question. Next, we have Brett Dahlberg from WXXI News, and after that, it'll be Brian Sharp. Brett?
Thanks, all. I'm going to go with the one question per person and then a follow-up. So I'll start with Dr. Mayo. What the state's guidance had been that there couldn't be more than 10 new hospitalizations for COVID-19 in the previous 10 days before elective surgeries could resume. That's not the case locally, in my understanding. So why is it? What do you think has changed, or what's your understanding of why it is that hospitals in Monroe County are allowed to open up?
Well, you correctly point out that that was one of the governor's criteria on his statement last week. That criteria has been removed from the two statements this week. Our opinion of that was that that was a thoughtful and helpful change, because that criteria did not account for population density in certain counties, nor did it account for stable overall COVID diagnoses. And because Monroe County has done such a noteworthy job of flattening the curve, we really felt that that criteria was not as applicable to us, and so we're pleased that that criteria changed.
Thanks. I'll direct my follow-up then to Dr. Apostolakis. What is it that you are doing at the hospital level to ensure the safety of both patients and staff? I want to know if you're going to be testing people before they're admitted, either for antibodies or for the virus, and what other precautions you'll be taking.
So depending on what the procedure, what we're going to be doing for the patient, for any procedure or surgery where there'll be aerosolization, we will obtain RT-PCR swabs of the nasopharynx to rule out active disease. This is both for patient protection and for staff and faculty protection. As far as antibody testing goes, we're still a couple weeks away from getting antibodies. And once again, that's the utility of that is more about looking at the prevalence of the disease and whether someone may be immune or not. So acutely, and in healthcare settings, taking care of patients, it's less helpful. What we've been doing to make our redesign safer for patients, faculty, and staff has been a lot of what we've been doing. Masking both the caregivers and the patients and any support person the patient may have with them, regular use of hand hygiene and other PPE, and social distancing. We're going to make sure that the schedules are set in a way that we don't have more than one person waiting in the waiting room. We remove chairs from some waiting rooms. We put tapes over other chairs to assure social distancing is adhered to. So a number of different strategies focused on social distancing and testing patients that will require aerosolizing procedures.
Sorry, I want to make sure I understand. Are the RT-PCR tests being done for everyone who's getting a procedure done, or does it depend on the procedure?
Not for everyone, but a good percentage, if not a majority.
Thanks.
Thanks, Brett. Brett Sharp from the Democrat and Chronicle. And that'll be followed by Diana Louise Carter from the RBJ.
Thanks. I think I'm going to follow the same. I'll start with Dr. Mayo. I was just wondering at Rochester Regional, going off of that testing question, where are you at in terms of being able to handle that extra capacity of testing, and is it, I guess, what has been done to secure those additional supplies?
Yeah, that's a really relevant question. It's certainly been one of the challenges throughout the nation and the world in managing this COVID-19 pandemic. So Rochester Regional Health began testing early in the pandemic locally. We were using at that time a relatively arduous manual process, and we were limited to about 160 tests a day, or within 24 hours. They were running nearly around the clock. Since that time, we've been able to expand our testing significantly. We can do 500 tests a day now, and we're hoping in the near couple of days to move to over 1,000. But testing capacity remains a really important part of succeeding in COVID-19. So we have had regular communications with the manufacturers of both the testing kits as well as the machines that run those kits. And in fact, we have a meeting today with RRH Laboratories about this very thing. So we're working this day by day and continuing to expand our capacity. We can't really quite have enough as the recommendations for more and more testing expand across the community.
Thank you. And for Dr. Apostolakis, I'm wondering, we've been hearing about the furloughs that are coming. How does this decision impact those? Are you needing the furloughs for the cost savings, but now you're going to need the people for these procedures?
Yeah, as far as furloughs go, I'm not directly involved in those decisions. I can only tell you that we have the number of staff, faculty to take excellent care of all our patients. And if it were my decision alone, there would be no furloughs. I don't know the extent, and I would direct those questions to our operating officer.
Okay. Thanks, Brian. And Diana, I think I recall you have audio problems with Zoom, so thanks for sending your question via chat. And we'll start with Dr. Pastelakis. I think this goes to both systems. But does the governor's decision mean any surgery is being allowed now? And if not, how are, or in addition, how are you triaging the types of surgeries that you're doing? So, Dr. A, do you want to start?
Yeah, so that's an excellent question. There's a backlog of a lot of procedures and surgeries that need to be done. And obviously, we're going to triage by the needs of the patient. So we'll start with the most urgent procedures and move on from there. There's also other things to look at that include, safety of the patient of the procedure. Do we have adequate staff for that procedure? Do we have adequate PPE for that particular procedure? And right now, we have all those things, but we're prepared if we do run shortages of PPE or any space that we will adjust our schedules appropriately.
And Dr. Mayo, same question about surgeries for Rochester Regional?
We're taking a very similar approach. Thank you for the question. Certainly, we need to prioritize patient needs, those who are more symptomatic as they're waiting, or if their condition has other particular requirements. In the case, let's say, of a cancer surgery where a patient may need subsequent radiation or chemotherapy, those cases we've been prioritizing all along, and we want to keep those patients in active treatment. So we'll be folding in layers of prioritization, but we'll be moving quickly because we want to open up as much surgical capacity as possible and as quickly as possible and as safely as possible. So hopefully these prioritization steps won't feel like much of an additional delay to our patients, but internally we will be considering these impact factors.
Thanks, Dr. Mayo. Next up is Jennifer Lukey from WHEC Channel 10.
Hello. I'm just wondering what the message is for those folks who have been waiting for a surgery. Will they be getting calls from their doctors to start setting things up? Should they be calling the health systems and seeing when they can squeeze in? And I guess let's just start there.
It's another great question, and we will call the patients, and we'll call them in order of urgency and need. And if there are patients that are concerned or feel that theirs is more urgent, we encourage them to call, but we will be calling all our patients to reschedule their procedures and surgeries.
And Dr.
Yeah,
Mayo?
I would say the same. That's the approach we're going to be taking, and we've been doing our utmost during this unusual pandemic time to stay in touch with our patients through electronic communications, through telehealth, through MyChart communications, and sometimes we just use the old-fashioned telephone works too. So these communications are obviously really important, and we don't want patients to feel like they've been overlooked. So they're welcome to pick up the phone too.
Do you think those will start this week, next week, a month out? Like how what's the timeline?
Oh yeah, we're starting this week. Yes, we will be calling folks and getting them set up. Some surgeries will be beginning this week, and then certainly we'll be teeing up the schedule for early next week.
And we'll be doing the same.
Okay. Thanks, Jennifer. Kayla Green from WROC Channel 8.
Yes, hi. So my question is, are there any surgeries that will still be postponed? Are there any at all that might not be possible to do at this time?
I'm not foreseeing that. Are you, Dr. Pastelakis?
No, right now we're open to doing all procedures. Certainly the ones that are less urgent will be put off still longer because as we ramp back up, we can't do all the surgeries immediately.
Yeah,
Okay.
It'll be the schedule, right? We'll be scheduling our patients, and The nursing teams will be, as professional and diligent as they always are, but we'll need to keep them, scheduled and appropriately balanced in the work. So we'll move it forward as quickly as we can.
Okay, thank you.
Kaylee, if that was quick, do you have a follow-up?
Yeah, I do have a quick follow-up. How long could it take to perform all of these backlogged surgeries? I mean, do you have any kind of timeline considering how many have been backlogged?
I would say that we've postponed now for over 5 or 6 weeks. It's going to take probably a few months to get them up, I would estimate, because by the time we start ramping up and get to anywhere near where we were before, it's going to take time, and then you can't do all of them on the same day. So I would say it would take weeks to months, but once again, taking care of the most urgent first and then the less urgent later on.
Yep, that's very reasonable. Yeah.
Thanks, Kayla. We're going to unmute Spectrum News. I'm not sure if you're a reporter on or if you're just rolling on this. So you're someone on Spectrum?
Yes.
Go right ahead.
Can you hear me?
Yep.
Hi, Lolo Rose from Spectrum News. My question is, since we're opening up for more surgeries, this for both hospitals, what does the supply of PPE look like? Is there a risk we could run short? What is that supply looking like as far as days, weeks, months?
Dr.
We have easily weeks of PPE. Our PPE supply for masks, gowns, shields, gloves, masks, and N95 masks is probably better today than it was at the start of the pandemic. We'll have plenty of PPE unless there's a loss of social distancing, another or a surge that could make us burn through our PPE. But right now, as far as PPE goes, it looks very good.
Yeah, that, of course, is a really important question, and it's been one of the major issues through this whole pandemic. We've been able to get through it because we've had tremendous community support. We've had just so many donations from people in this community. We've had local manufacturers step up and help us produce PPE, and for all that, we're really grateful. And as we've continued to work with our suppliers, they have been able to step forward with ramped up productions. They've done that various ways through expanding their networks, as well as some of the factories both here and abroad expanding their capacity. So our current PPE resources are very favorable. They are better than they had been earlier. I would say a month ago was probably our tightest time, though we were still managing, day by day and providing what we needed. Daily calculating the consumption rate of PPE remains a major part of our work, and that will continue. And I think what you're pointing out is that as we start to ramp up and return to usual levels of clinical activity, we'll now be using a lot more PPE than we did prior to the pandemic, and that's absolutely true. So we'll continue to measure daily, and we'll continue to report to our teams internally and do everything we can to ensure that that does not become a barrier to safe care and efficient care.
Lowell, thanks very much for your question. And before we turn it to Will Astor at Rochester Beacon, I'll ask if any of the reporters have a follow-up question, if you could just alert us on chat. If we have 2 or 3 follow-up questions, I think we can allow time for those. So send a message via chat if you want to ask a follow-up. And with that, I'll ask Will Astor from Rochester Beacon if you have a question.
Yes, this is, I think, for both Dr. Mayo and Dr. Apostolakis. Does this extend to ambulatory procedures and ambulatory clinics as well?
Yes, I'll take a
and
stab at that
let
first.
me just say, is the backlog similar or greater in those kinds of facilities?
it certainly does apply to ambulatory procedures, and fortunately both UR Medicine and RRH have good resources in the ambulatory surgery space, and so we can use those facilities. Those facilities were closed based on the initial executive order and for the desire to focus resources to the hospital setting. But we will be opening up ambulatory surgery. We're excited about that, and we think that we will be able to catch up with the backlog there, but it's similar, and so it'll take us a few weeks to catch up with that, but we hope in a fairly short time the patients of this community would feel like their needs have been fully restored and met.
And in terms of ambulatory, does this also apply to private ambulatory centers?
Yes.
Yeah. Okay.
And Will, did you have another question for Dr. A, or?
No, I think I'm okay. Other people answered or asked my questions.
And sorry, I'm going to just read from the chat. Steve Orr, I see Veronica has answered, and Dr. Pasalakis said in the opening, both the governor's executive order that's allowing these elective procedures encompasses all of our hospitals and clinics, I think, in both systems. And Jennifer Lukey, you were first to jump in and say that you had follow-up questions, so we'll turn back to you.
So the governor wants to make sure that you still have 30% occupancy open and available in case of a second surge or in case of an increase in COVID. Where do you normally run with occupancy, and how big of a blow is even leaving that 30% open?
So our occupancy, when you include our children's hospital and our cancer hospital, is roughly in the neighborhood of 800 to 900 beds. With surge capacity, though, we've been able to identify and that we'd be able to staff, closer to 1,200 beds. And so we're able to normally run at about 100% occupancy, but now we're running well below 70% occupancy for our surge capacity. So we still have a lot of room to grow into for both surgeries, for procedures, for regularly non-COVID illness, and the ability, if there is a surge, to take on a couple hundred more patients almost immediately with COVID illness. Now, as we said, if there is a surge, we'll have warning through the community, increased number of tests, increased symptomatology in patients seen in primary care offices. So we'll have warnings of this, and we'll be then shutting down surgery like we did when this first started to assure that we have even more capacity.
And Dr. Mayo?
Yes, an important point to make in your question, Jennifer, is that the pandemic and the collective assessment of resources that was requested of the state have redefined in some ways how we think about capacity. And so capacity is really no longer just the number of rooms in a hospital. It's how do you use the entire space within the four walls to take care of patients. And so, as Dr. Pasalakis is explaining, we can expand quickly. The COVID pandemic has changed in some ways how we think about that for the betterment of the community and the availability of medical resources. So we're not concerned about being able to ramp up quickly if we need to address a unexpected spike in the COVID surge, but we feel that we keep those requirements and move forward with routine care as we were familiar with it prior to the pandemic.
Thanks, Dr. Mayo. I see Andrew Banis has one follow-up, and there's two more questions in writing that I'll direct, and then we will wrap up this briefing. Andrew, do you want to ask a question?
Yeah, part of the guidelines here is also making sure there's a plan in place for when flu season hits again in the fall. wondering if those preparations are already underway for that as well, not just COVID-19 or possible surge there, but also flu in the fall months.
I like how you're thinking ahead. I'm sorry. Yeah, that's absolutely true. We were just talking about that yesterday and today as we were continuing to refine some of our staffing models because we have to be prepared for flu. In some years, flu is really a challenge to manage, and so we now need to be prepared for both flu and COVID overlapping, and so we are planning for that now.
Right. And a lot of the symptoms of the flu and COVID-19 are very similar, and it's believed that a lot of the spread is very similar. So a lot of the preparation that we're doing now for COVID-19 also is preparation for influenza, preventing its transmission, and hopefully what the community is doing as well will limit the spread of flu just like it's limited the spread of COVID-19. So we're very hopeful that the flu season will be relatively mild this year because of the social distancing.
Great, thank you.
And Dr. Mayo, we've got a question in writing. Will Rochester Regional be testing either for the virus or for antibodies before admitting patients for procedures?
Yes, we will be, and we've already started that. So when COVID testing first began, it was fully focused on people who were symptomatic. And the accuracy of the test is in part based on the clinical conditions or the clinical characteristics under which that test is utilized. So when you begin using that test in a different clinical setting, by that I mean asymptomatic people or just general screening, the interpretation of that test accuracy changes. And so we have been working through that, and I know that URMC has also been applying this to asymptomatic patients as a screening tool. And so we have also begun that. So we are in the process of phasing that out. We ultimately would like to expand that greatly. And it wouldn't be surprising if in the future there's much more widespread asymptomatic testing. And the test itself will probably improve in accuracy and will also be improved in its interpretation with the coming online of the antibody test. So there's a lot of things that will be changing with testing over time. And I'm looking forward to all that because that will only help us take better care of our patients and will refine the science around this disease.
All right, thank you. I'm going to close out asking more questions. We'll stop with Brian Sharpson writing. Before that, Max Schulte had a question. What's the landscape look like for local supply of PPE to be a sustainable model for both systems instead of relying on supply chain from outside the United States?
Well, the supply chain is much better than it was before. What the future holds, I think, depends on what happens in the whole United States. If we're still able to bend the curve in the whole United States, the supply chain will come from the United States. But not knowing the future, we're keeping our contacts everywhere and making sure that we're able to get adequate supply to protect our patients, faculty, and staff.
Yeah, that's a great question, but it's above my pay grade because it really goes to national and international manufacturing and trade and regulations around a lot of those things. I do know through our internal communications that some of the national producers are looking at how they can step forward with more and more production to provide U.S. independence in this area, but I really don't know how that's going to evolve over the next weeks and months.
Thanks, Dr. Mayo. And last question from Brian Sharp for Dr. A. Can you give some thoughts about testing capacity and supplies, where we are on that?
So it's very interesting. Our capacity has increased rapidly. I think our peak day we did over 800 tests. We have the capacity now to do 1,000, but it's interesting in that the amount of reagent is limited to the amount of tests you do. So the more tests you do, the more reagent you get. We believe that we have the capacity to go as high as a couple thousand tests a day, depending on what the needs are, and if we have adequate reagent, we can do that. As far as the antibody test, which is a check for immunity, it's a blood test, it's not the swab. That test we should have up and running in the next couple of weeks. We're validating the equipment right now, and that's a test that looks at what the prevalence is of the disease in the community, how many people have antibodies, how many have been exposed, how many people possibly have immunity to the disease, and that helps with the decision of when you can open a society more. And so we'll be embarking on that in the next couple of weeks.
All right. Thank you, Dr. Mayo, Dr. Apostolakis, and everyone in the media for attending on short notice. And we will end the meeting for this briefing on the governor's executive order today.